everyone. I'm Daniel Fang. Very happy to see all of you. And I can see that we also have people as far away as Cambodia. So good morning, good afternoon, good evening to people from around the world. Welcome to the IACAPAP's, well, we're calling it the Brain and Breakfast webinar, from where the source of this webinar is coming from in the eastern coast of the United States, even though Gordon has the western coast of the United States in his background. But it's early morning there, and we're very happy to have all of you. My name is Daniel Fang. I am the child psychiatrist from Singapore, and I will be your host for today. Today, we have a very interesting webinar on the 5 languages of psychiatry. And our speaker is none other than Gordon Harper, a psychiatrist who's trained as a pediatrician and as well as a child psychiatrist in Boston. He has worked in acute hospital care for several decades, and I think that's an underestimate. And then worked in public sector child mental health as a senior child psychiatrist for the Massachusetts Department of Mental Health. In addition, providing frequent consultations in child protection systems in Massachusetts Department of Children and Families. He's also served as treasurer of the International Association of Child Adolescent Psychiatry and Allied Professions, or IACAPAP for short. He holds academic appointment as the Associate Clinical Professor of Psychiatry at Harvard Medical School and has taught widely internationally. He has written on inpatient treatment, medical education, healthcare policy, care planning, managing the ambiguities of child protection. But most importantly, Gordon is my friend, my colleague, mentor, and really someone that I look up to from our part of the world. So today, Gordon is going to share about the languages of psychiatry and how we can listen and learn from one another. And what better way to do this than from 2 poles of the world, in North America and here in Asia, where I am. So Gordon, it's all up to you now.
Thanks very much, Daniel. That was really a great, wonderful greeting and welcome from a good friend and colleague, Daniel. It's such a pleasure to have Daniel as a friend in Singapore. Folks, I'm going to talk about the languages, in particular the 5 languages of psychiatry. And I have no conflicts of interest. And we start with the acknowledgement of the problems of psychiatry. Many people say psychiatrists just push pills. We've lost the distinction that Osler made, the emphasis on the person being more important than the disease. The person with the disease is more important than the disease with the person. Salzman here, Carl Salzman has just presented this at the American Psychiatric Association, the loss of what he calls compassionate psychopharmacology, in which the person is not just someone to get pills into, but someone we want to relate to. I've used the term clinical binocularity, which means that we can see and think about 2 very different things at once. This came to me when I was talking to a colleague who had seen a friend at a ceremony walking down the aisle to get an award, and he noticed that the friend had a difference in his gait, which indicated he had some kind of motor problem, neurologic problem starting. So he was able to say, I'm both with my friend, appreciating his getting this award, and also I can see there's something coming on here in his nervous system that he doesn't see. So this was what I called binocularity. James Beck is well known for his book, Psychiatry in Trouble, that deals with much of this. Now, what's driving this change? Well, some would say this is simply due to our overemphasis on the biological, biomedical side of our new knowledge. That's very important. But there's also the point that's made that much of medical training discourages us from feeling uncertain about things, that the goal of medicine is to know a diagnosis and to be sure about it. And for instance, one of the ways this shows up is, it used to be when Daniel and I were in training, at least in the US, you could admit somebody to the hospital with a diagnosis like rule out appendicitis. Nowadays, you can't do that. You have to say right lower quadrant pain, because you can't use a rule out as a diagnosis. In addition, of course, there are tremendous administrative and corporate pressures to define things in biomedical terms. Today, we're going to talk about something a little different, the ways we talk about and with patients and with each other. My goals for the participants this morning will be to recognize the different ways we discuss conditions in psychiatry, to appreciate the consequences of these different ways, to learn some possible fixes, and to appreciate the need for continued study. Here are the 5 languages I will talk about. Descriptive, categorical, experience near or empathic, etiological, and developmental recovery. Let me say something about each of these and how different they are. The descriptive is one that names the phenomena that a patient has that are observable by others, sometimes by the person himself. So that, for instance, the patient has a depressed mood. For instance, the patient has emotional overactivity. Patient has narrowed interest. Then in the second category, the second language, these are put in categorical terms. It's not just that you have a feature that can be described, it's that you have a diagnosis. And of course, we have ISD-9, but we also have DSM, and DSM puts things in categorical terms. The third category, the third language, is that of experience near, which is to be able to put things in language that works for the patient. For instance, it sounds like every time you make a new relationship, you're worried about that relationship breaking up, or you're erupting into anger. It sounds like you don't have the energy you usually have. It sounds like you've lost interest in things. These are experience near statements. Etiological statements are statements in which we try to say where something is coming from. Well, this is the result of genetics, family history. This is the result of early experience. This is the result of trauma in early life. And etiological is very important. I would emphasize, though, that sometimes etiological gets in the way of an empathic statement. For instance, if somebody says, "Why do you feel depressed? You got things are going pretty well for you," or "Yesterday you felt good. Please justify to me why you feel this way." That's an unempathic push for etiology, in contrast to simply saying, "It sounds like right now you're feeling this or that way." The fifth language is in some ways the most interesting and most challenging. It's to put things in terms of development or recovery. For instance, to say, patient has some early signs of what may be a serious mood disorder. Patient hasn't recognized these yet. Patient has a problem with gambling. Patient is not acknowledging that problem. Or so we'd say patient is at an early stage of recognizing, let's say, his problem with gambling or his problem with alcohol or substance use. That puts everything in historical developmental perspective. Here's an illustration of the five versions, and I'm seeing my. I'll take this away. So as I said, the descriptive statement, for instance, is a pattern of instability of interpersonal relationships, self-image and affect, and marked impulsivity. That's what you might see in DSM-5, but the DSM-5 would also put this as a categorical diagnosis. That's borderline personality disorder. It's not just those features. And we know there's a lot of debate about which features should justify particularly personality disorders diagnoses. The experience near, as I said, is to be able to say, you have or people have lots of ups and downs in relationships, often leading to breakups. As an example, you can feel like you're always living near the edge. That's an experience near statement. Etiological statement is, as I illustrated, to talk about genetic vulnerability, sequelae of trauma or other adverse life experiences, or altered neurocircuitry. And the developmental recovery statement is one that tries to put this in historical developmental perspective. That, for instance, to say, this person is at an early stage of recognizing and learning to manage that he or she has these instabilities. So you see that we've gone from describing the pattern of instability on the far left to categorizing it as DSM would do as a disorder, to talk about how it feels to the person, speculating about etiology, and then finally putting it in terms of recovery developmental terms. It sounds like this person is at an early stage. It sounds like you're just beginning to recognize this as a problem. So as I said, that's what the descriptive language represents, pattern of instability of relationships. The categorical is to put this as a disorder. Experience near is to say, as we said, you have lots of ups and downs and feelings and relationships, often leading to breakups. And it's not easy to sort out the have-tos from want-tos. Etiological gets into speculation about where it's coming from, genetic vulnerability, sequelae of trauma, and early other adverse life experiences, or altered neurocircuitry. And finally, the idea that everything is something that one has to deal with, first by recognizing it, and then by being on a path, often not by recognizing. For instance, if a child is just getting used to school or to high school or to college, we can say the child is just getting to know what it's like to be away from home, to be living with other people. This can all be stated as a pattern of learning to manage new situations. So with regard to these different languages, it's one thing for us to be aware of them. It's another to ask, what words does the person, him or herself, use for their condition? What words has the person heard professionals use? How has the person felt about the words used? Do they fit? Do the words make them, how do the words make them feel? Different, sick, ashamed, hopeful, understood, respected? This subject is getting a lot of discussion now, including in the public media, particularly in the US. I don't know how it's happening in other countries, but in the US there's a lot of discussion now about people's experience of getting or not getting psychiatric diagnoses. And as we'll say in a minute, sometimes that's great relief. Oh, finally there's a name for what's going on. Sometimes it's the opposite. Oh my God, I don't want to be given one more label by psychiatrists who don't know what I'm up against. As I emphasize, this is an example of how people can feel understood. And feeling understood has been very important to me in my work. These are expressions I've learned from people that help to feel understood. Wow, that must be hard to say. I had no idea. It's hard to hear, but glad you told me. That one, I'll tell you, has been so important. I actually have a, wait a minute, put this here. Can't see this very well. Yeah. All right, anyway, that's a poster that says, difficult to hear, but I'm glad you told me. Pretty brave to say that. It's a very important thing to be able to address the courage, the determination, whatever is often involved in making a statement about how you're feeling. I'm sorry to hear that. I'm sure I get it. I'm not sure I get it, but I want to try. I want to hear more about how I may have hurt you. Very important thing to be able to, for doctors to be able to say to patients, I wonder if what other doctors, I wonder if what I said has not felt good. These statements from patients represent not feeling understood. Well, why do you feel that way? How could you feel that way? You can't feel that. I've done so much for you. Yesterday you said that, oh, that makes me feel so bad. This is a great impediment to communication with patients, is for a loved one or another person, or especially a doctor, to say, oh, that makes me feel so bad if you're saying that. And then finally, why study art? You'll never be a Picasso. Some of the ways forward. One of them is to check with other specialties in other countries. I'm hoping that Daniel can join this topic later on, and we've talked about this a little bit. Another is to include this topic in curricula. I don't know of any curricula now in the US or in other countries in which the 5 languages are spoken about and differentiated. To collect clinical stories, to develop clinical exercises in which students have to deal with the several languages and to measure outcomes when the above are done. So our conclusion is that psychiatry contains several unrecognized languages. They're quite different from each other. Each contributes to knowledge and understanding, but failure to recognize these differences can complicate care. And there are some ways to increase communication and understanding. Now, so far, what I've presented is based mostly on Western experience, but I'm glad to have Daniel here to move the discussion forward and talk about how this sounds to people whose experience may not just be in the U.S. or in Western Europe. So I'll say thank you and pass the microphone on to Daniel.
Well, okay. I hope you can hear me, because I noticed that some people have highlighted that we were a little feeble in the sound. I hope that all of you have corrected your volume controls. We are, after all, really speaking from two sides of the world. And actually, I'd like to encourage our participants, and we have 131 of you, to come in with your comments. But really, thank you, Gordon, for this very elegant, thoughtful presentation. You've given us a new grammar for psychiatry, one that reminds us that the way that we speak about patients and to patients profoundly shaping their, really how we do it really shapes their care, their dignity, and therefore their healing. Your concept of psychiatry as comparing multiple languages, descriptive, categorical, experience near, etiological, and developmental recovery is a real mouthful, of course, but it's both clarifying and confronting because it helps us to see that many of our clinical misunderstandings are not about facts, but about framing. We speak in DSM while our patients speak in pain, right? We think in etiology, but they yearn for recovery. So in Asia, where I practice, these issues are often magnified. There may be less verbal expressiveness, but not less emotional complexity. A patient might never say, I feel abandoned, but there are sleepless nights, there are somatic complaints of silence, may shout it. Language, especially in high context cultures, includes what is not said. What we desperately need is what you described as clinical binocularity, which is very important, even though I'm not sure people even use binoculars these days. They've got their cell phones. The ability to see with both eyes, the professional and the personal, the scientific and the human. I would add that we also need cultural trinocularity, to see what with a third lens that includes context, family, and community. And perhaps even more importantly, perhaps we should see and strive a quadricularity. That's really a mouthful, by adding the spiritual lens. Now, many of our patients turn to meaning, faith, or belief in something greater, especially in moments of suffering. This spiritual language, often overlooked in clinical settings, can be central to recovery and resilience. So in Singapore and across Asia, we are exploring how to train our future psychiatrists, not only in EPAs, which I think in American residency you understand as the entrustable professional activities for competencies that are necessary as psychiatrists, but also in empathy, presence, and the ability to translate across these psychiatric languages. You've reminded us that the right words can heal. I want to understand. Thank you for telling me. That must have been hard. These are small phrases with immense power. So let us take your call seriously to listen more deeply, to teach these languages in our curricula. And I'd like to believe that that's the second half of my career as I stop the administrative, run the hospital job that I do, and perhaps do more of that working on developing the skill sets, the competencies, and perhaps the heart of our discipline, what it means to care and to help people in suffering, make psychiatry not just a science of the mind, but a practice of meaning, compassion, and hope. So that's my rejoinder to the presentation. it's a short summary. I believe that I may have provoked, therefore, some questions. I hope. Let's look at. Is there any
Thank you,
questions?
Daniel.
Yeah.
Let's see what kind of questions we have.
Okay, let's see. Can we get a copy of the slides afterwards? Yes, the answer
Yes.
yes, of course you will. In fact, I'm hoping that Gordon will write this up and we can publish this because I think we need to do that again with the efforts that you've done and presented. We have a question here from Shigeri Toki. How do you think of the relationship between the therapist and patient? In modern psychiatry, we try to eliminate the relationship from the diagnosis, opposing the psychodynamic perspective. In the case of BPT, I presume it's bipolar or borderline, I don't know. BPT, we use the idealization and devaluation. I'm concerned that such a perspective is being lost so that our clinical technique would be regressed. Gordon, this is a difficult question.
One person who's addressed this very well is Carl Salzman, whose career has mostly been in psychopharmacology, but who gave a terrific presentation and presented this week at the American Psychiatric APA
Yeah.
on
The future of psychiatrists?
it was on the compassionate
Okay.
psychopharmacology. And
Okay.
he's pointing out here that it's not just to diagnose a condition and prescribe a medicine, but it's to make a connection with the person. Well, how does the person understand his or her problem? Does the person feel understood when the doctor prescribes something? Or is the doctor prescribing something just to get you out of the office and be done with it? And that gets to the point that the person was just asking about relationship. This has everything to do with relationship. I appreciate the question.
Okay, another question here from Ursa Reve Loza. What do you think about the importance of nonverbal language? So what patients are communicating without word and what we are?
That's a good question.
Hmm.
That's a really good question. I'd love to hear some examples of that.
Sorry, what do you say?
I'd love to hear some examples of nonverbal communication. I think that would be very enriching this this effort.
Yeah, it would be. And I think in our context, very often, at least in my context, I see families come in and then there's this silence, right? Nothing is said. But then we do see some, the way they sit, the way they're looking at one another. For me, I think there's a lot of, especially when we see families, you'll see some of that non-verbal going on. The child will speak and then look to the parent. And then sometimes you ask them a question, they don't say anything, they look to their parents.
Right.
Yeah,
Right.
that's the most common one. And then you're wondering, right? And then which parent they look to is important. And so I think those are some examples. And of course, we do see children who don't speak at all, right? Selectively mute child.
Yes.
But they do communicate. So we must be sort of aware of those communications. Sometimes it could be the way they come in and hold, sort of say hello and shake your hand, and then after that become mute. And sometimes it's the way they sit as a family, who goes where. I often recall the parent coming in and then grabbing the seat right in front of me, and then there's actually a bunch of seats pushed to the identified child to some corner in the other end. So those are clues actually for what we're about to sort of experience.
One of the people in the chat just gave a good example of crossed legs and arms. It can be a sign of a patient feeling relaxed and comfortable in the office.
There's a question here, can empathy be really taught to new doctors?
Yeah, I thought that was a good question. And you know what I've been impressed with and I've written about is the extent to which we let medical students be heard and understood. And this is very important because, as everybody knows, medical training involves unlearning a lot of social rules which we've learned growing up. You learn not to talk to people about private things. You learn not to touch people's bodies. And in medical school, you have to unlearn these things. And the paper I wrote about this a long time ago was called Breaking Taboos, Becoming a Physician, breaking taboos and steadying the self. And there are several parts of this. One is simply to acknowledge this is going on. I'm not sure how consistently in medical training we acknowledge what a rupture this is with the socialization which good people have had before getting to medical school. That's one thing, simply to acknowledge it. And the other is to give the students a chance to talk with each other about what is going on. And one of the most powerful interventions I've seen was during the preclinical years and also during the clinical years, to have discussion groups in which the students could share with each other and with a sympathetic preceptor what was going on. Very important to have the faculty for this not be the same as the faculty on the unit where you're doing your clinical training, because of course the faculty there is interested in taking care of the patient. He's not interested in, he may not be interested in what's going on with you as an individual. So, or especially if you're having a bad experience, you don't feel you can share that with your preceptor in the hospital. But if you come back once a week to the medical school or to some other place and have a chance to say, this is what's going on, that's really important. And my argument is, I don't know evidence for this, but I think this is true, is that the extent to which a medical student has that kind of experience of feeling understood, being able to talk about what's going on, I think that shapes very strongly what the student can do later as a physician. That is, if you feel you've been able to talk about what's going on, you're much more likely to be able to listen to patients when they're talking about what's going on.
Mm. And I guess it's also important for students to reflect, as they are in their learnings, rather than just purely on the very pure, very diagnostic approach towards, sort
Right.
of, what you're going to do, and to actually either at the beginning or the end of the sort of session with the students, to have a chance for them to sort of, well, how do you feel about what just went on, and sometimes you just getting them to share as a group is helpful. For residents, I think sometimes a lot of the learning is around working, and so they are rushed by the just sheer numbers. It is important not to spend not to just focus on the work that needs to be done, but also on the relationships that have developed so I think that's part of that learning. And I think it's a good question, because we don't often think of this, and we often assume that it will be learned along the way, and it's not easy, particularly if some of the students are so clinically sort of they're just oriented around what's the diagnosis, what are we going to do about it, and I think in psychiatry, more than anything else, it's not just about passing the patient through the mill, the sort of factory that we're trying to produce a result, and to think of the human being behind the stories that they tell. So I think this is a reminder of what you just said.
Good. One of the other questions had to do with transference and countertransference. Really good question. Certainly when we talk about relationship, the more we can think about what may be being borrowed or brought over from other relationships is really important to appreciate that these experiences on the patient's part and on our part may not be entirely new. They may be representing very familiar patterns of responding.
Here's another point. Any advice for early career child psychiatrists navigating in a quite often dichotomic world, numbers versus people, feelings versus actions, humanity versus science, alongside the time and objective outcome pressure of systems?
Now, one piece of advice I often use is to encourage the student who's missing this part of the discussion to ask the preceptor, ask the teacher, what do you do to make sure you understand, to help the patient feel understood? Ask a question to the preceptor, you ask your teacher, which is a legitimate, understandable question. So how do you know whether the patient feels understood? And to ask that of the preceptor, who may be talking only about diagnoses.
Mm-hmm.
Or you say, how do you go about finding out how this diagnosis is sitting with this particular person? And Daniel, you referred to some of the family context. You can also ask, You know, if the person has one reaction to a diagnosis, what's the person's sense of how the other family members will respond?
Yep.
Some will say, never want to tell them. Some will say, oh, finally, they got a way of understanding what's going on.
In fact, I think a good experience for the student and also for the teacher as they are taking students through a live case, and that's how we do it here in at least in Singapore. They would be seated in the room, and we'd have introductions of everyone. Then we start the conversation. Sometimes we're doing it even online like this in a sort of Zoom-like environment, telehealth. Is actually for the preceptor in your case to teach and both the patient about the problems and then take that opportunity with the students around to sort of discuss it. It's kind of a discussion rather than just okay, this is what we need to do. Very often, I mean, in my practice, I do not say, okay, we got this diagnosis, this is what we should do. I often ask them, what are their expectations? The last question that I often ask is what, well, I ask it in my mind first, and I often tell the students, think about it, is what is the reason for their being here? Because, you know, it could be, you know, now when he's 10 years old or when he's 15 years old, why now? You know, and are there reasons that we are not entirely clear about? So in Singapore, for example, one context could be there's a major examination, they need a letter, the parents are in conflict, and the child is merely an excuse to bring that conflict to the fore.
Right.
Those conversations sometimes come up. But it's important that as we evaluate what's going on, to think about that. So I often sit down with students to talk about that. So that's one way to sort of bring out some of the those issues. Here's
On the subject, Daniel,
yeah.
of people's experience being acknowledged or not, I had one great example, a learning experience for me. A patient I'd seen in the office for a long time when COVID came, we had to talk on the phone instead of in person. And on the phone, the patient revealed that he'd always felt really uncomfortable in the office, that sitting in the chair across from me, and that he also felt uncomfortable in the waiting room with other people. But he never mentioned those things. They've been going
Until
on
he was on the phone with you.
only because of COVID and the phone
Yeah.
interview. Could he tell me that?
And so I think actually the beauty of our psychiatric evaluations that we have opportunities to see them in other settings compared to most of medicine. We actually have that opportunity. We don't, whether we use it is another matter. Here's a question about the wait, is this a question? Oh no, this is about okay. That's Sue Wong's point, is it? E-certificates. Okay. Yeah, okay. No, I thought there was an additional
One of the
question.
questions, Daniel.
Yeah.
The question is, why do we talk about 5 languages? Could there be more? And obviously, as you were pointing out, there certainly could be more. One is the cultural language, and another is the spiritual language. Really good observation. I'm not saying the door shuts at 5.
Yeah. No, and having too many languages, we have a problem with trying to remember too many. You've already got a mouthful. We're going to make those words a little easier for you to remember. I'm from Portugal. We are receiving many patients and families from different countries and cultural backgrounds. What do you think is the most important in our communication with these families? And well, actually, you know, IACAPAP, we just had our World Infant, Child, Adolescent Mental Health Day annual sort of advocacy seminar where we were talking about displaced families and displacement. Obviously, most of us think of it in terms of refugee situations, war, but displacement can happen even in our own countries where, you know, children are taken out from, you know, what we deem as potentially disruptive and abusive or neglectful environments to place them in other places. And there's a lot of challenges for doing that because the child is placed in a very unusual and a foreign kind of an environment that makes them feel very uneasy. And if not handled properly, can itself be a traumatic event. So how do we deal with families? My approach has always been to try and bring some familiarity. Just the same way if we have a patient with dementia, we try to bring familiar environments or familiar people. So with children, the same thing, what is a familiar environment? It could be toys, it could be something that they're used to, like in the school, or there's some adult that they trust, because those are the people that you would want to be present in evaluating them rather than just having them sit in a cold room like Gordon's patient, uncomfortable, and just because they're kids, they're not going to tell you I'm very uncomfortable initially, at least.
Right.
Yeah, and so maybe that's yeah.
Another special aspect for kids, this came up in response to the question of kids who are traumatized or come from different places. One of the big challenges for adoptive children is to feel that it's okay to miss where you've come from. I've people who've come from, let's say, from an orphanage in Russia when they were 5 or 6, and they quickly got the message in their adoptive home that they were supposed to be grateful, appreciative. Thank God I'm here, not in that lousy orphanage anymore, and to say, I miss the orphanage, I miss the other kids, I miss the preceptors. It was really good. It was very, very difficult for them as they tried to be a good kid for their adoptive mother.
Mhm. Yeah, and I think it's helpful to be, I mean maybe it's linked to Shigeru's comment about aging makes us emphasize to our patients. I don't know whether he means we nag too much and it's stressful to emphasize, and tell them, and sort of focus less on the science and the disease and more on the person. I often tell my patients, I really don't know what's going on here. It's really helpful for them to hear that sometimes.
That's right. Yes, because that cuts away at one of the unspoken transfers is here, which is the doctor knows everything and the patient knows nothing.
Mhm, mhm.
And so when you put yourself in the position of the learner, it's very empowering of the patient. Now,
Okay,
one of the other questions was looking for literature on the subject, and there I take Daniel's suggestion seriously. We've got to get this into print in the in the literature. I'll be glad to send or I guess Sue has the PowerPoint. She can make that available, but it needs a lot more development.
Well, the point about the generative language models, the large language models that are being used by AI in child and adolescent psychiatry, you're not wrong. AI-enabled chatbots, and we've got some research that's coming out already from Singapore that you can actually help in that conversation. I'm not saying that it's going to replace it, but it'll help you with some of that factual stuff. And we've been able to do a forum that is AI enabled, so people can ask questions. The AI chatbot actually develops the response, and then we have a human sort of go through that and put it up so that the forum is really live and active and fast. Because the problem with all forums, is you get 100 questions. To respond to all of them may take time. So I don't think AI is going to take away some of this. It's going to help in the process. It's going to make responsiveness a lot better. And then at the same time, you still have to add the human touch, because there's one thing that AI cannot do. AI is based on the information that it has. It takes language, it builds on it, and of course it can learn. It can learn to be like Gordon or like me and respond in what we traditionally do, but it's based on the history of what we've done. So it's not going to be able to come up with a response that is completely human. So I think the human factor is still necessary, but it can help, and that's definitely. There's a question here about the busy psychiatry clinic, all amalgamated into one ad hoc language determined by time pressures and patients' need. There's no way to consciously or meaningfully separate the languages. Naveed's point. What do you think, Gordon?
Well, it is hard to separate them, but at least to be able to conceptually distinguish them and say, the patient comes in saying, I have this, and the doctor says, no, you have this condition, you have this diagnosis. Well, that's a point for communication between the two to say, okay, does this term capture, or does this term seem kind of off-putting? We I don't think patients have always felt permission to say, I hate that psychiatric diagnosis.
Mm, mm, mm.
We
Yeah.
expect patients to say, oh, thank heavens, I I've got a diagnosis now. This good doctor gave me a diagnosis, and it doesn't always let the patient feel there's room for saying, you know, I have mixed feelings about the diagnosis.
Yeah, and somehow I'm just reminded the thing that we do have to spend time. There is no such thing as a rapid consultation. Um, uh, there's only but the key, I guess, is that because we are resourced in a certain way, and there's no way to get around that, we have to ask ourselves, if we really have a really busy clinic, how do we sort of make time for each patient that is
Mhm.
reasonable, or you have to extend the time into multiple instances. I sometimes feel that we are all rushed to come up with a concrete sort of solution without sort of saying, hey, I need more time, I need to make another appointment, but here's what we can do at this point. Well, is there anything urgent? So the psychiatrist will probably need to be able to sort of, sort of formulate around these sort of things and say how you do it. I mean, ideally, we could spend a whole day with a patient or several days, but I don't think that's feasible in terms of practicality. So we have to do what we can for the time. But I think what we're trying to say here is the languages give us a dimension to consider and the different
Mhm.
aspects of what represents the patient. And I think for child and adolescent psychiatry, it's the entire family that presents itself, which I think is sometimes quite challenging, but also very enriching, because when you help the child, you may be just doing more than just the child, it's the entire family that benefits from this interaction.
Right, right.
Okay, what's this question about? When dealing with adolescents, a conversation with a teen before engaging the parent often provides two very different sets of information. Interview with the patient and parents may require two completely different approaches. Yeah, I don't disagree with that. Yeah.
That's right. I'm with you on that.
Hmm. And we've got another point here. Think of children and adolescents, how their parents feel about the patient's diagnosis managed at home. Managing it at home affects how the patient feels about it too. So about adolescents, I mean, I came off from a clinic. That's why I was telling Gordon I'm a little exhausted today, and I just remember, because I had these two conversations. I had the mother and her teenage son come to me. The teenage son had, and just the background to the story is that he has been a very good child up to now. And then last year, the major, where he was taking a major examination, he had a girlfriend. And mom's interpretation is that once he had a girlfriend, he completely changed. He pierced his ears, he colored his hair, and he tattooed his body, and his results became really bad. When I talked to the boy, it was more about, here's someone I met who's listening to me, and I feel so you know relieved that I now have someone I can share with. There's nobody else in the world that would listen to me with this patience, and I'm free to express myself. So these are two different conversations of the
Right.
same person. And how would the mom says, do you think that he's got ADHD? Perhaps you should, and the boy is saying, I need someone who understands me more. And I mean,
Great
mom's
example.
closest to me, but I've got this girlfriend who makes a big difference.
It's a
Yeah.
great example.
Okay, what's this one? I suggest taking the last two questions with you. Okay, that's Sue. Okay, last two questions according to Sue. We're running out of time. Yeah, please feel free to give us two questions. Anyone? I mean,
I'll mention one other thing quickly, Daniel, which
yeah,
is
go
that
ahead.
uh, uh, companies now are really interested in getting feedback about what I can't get anything from my local drugstore without anything, whether it's a 2 minute visit or a 20-minute visit, without getting an email the next 6 hours. How was your experience there? And I think for the corporate world to be so interested in this, I think it's a take home for us to say at the end of any interview, how was this interview for you?
Mm. Well, I think we do this, at least in Singapore, we do have this patient experience surveys that are done. It's not done by us. They do it sporadically and sampled, which is what we're experiencing in the rest of the corporate world. But it would be better if we actually ask that question. So I know that psychologists, at least in Singapore, they do have this post, sort of consultation evaluation kind of quick.
Uh-huh.
And they use it as part of their outcome measurement. I think it's important to ask about the experience, and then use that to sort of help you understand whether they got what they want. It's linked to my last question, which I always said, why is this patient here? I hope that the consultation allowed them to answer some of those queries they may have, achieve some of the goals that they want. I think it's important for that. I mean, because we're trying to serve them in a way that they would find meaningful. They're not here to get a diagnosis often. Not many. There are some because they need a letter to send somewhere, then the diagnosis might be meaningful. But sort of being aware, it would be terrible if we as a psychiatrist would listen to them and then come up with a diagnosis and then send them off on their way. And they said, actually, I came here to talk about, just to share about my problem because it's a burden on me. And
Right.
I got, I've got a couple of pills, and that may not be what they want.
Here's a question asking for a copy of the PowerPoint. Yes, definitely. Sue has the PowerPoint. She can share it with anybody. I'm very interested in sharing it.
Yeah. And I think what will happen is that this entire webinar will be available online. So it won't be live, it'll be recorded, and people can watch it as well. And then we'll try and share the materials as well. Sue can tell us whether she can do that. She's muted herself, so we assume that she can. So I think, yeah, I think we, we we have a lot. Thank you. And I think just final words, perhaps. Gordon, you want to say something to close us? And
I really enjoyed being able to present, and I really appreciated the range of comments and questions we got.
Yeah, I think it's great to see people from all over the world. This is a very kind of troubling time for the world. I think much is happening all around the world, and Gordon will know this. And hopefully we don't forget the reason why we're here. It is our goal is really to be able to provide compassion, hope, and understanding to patients, their families, and to provide kind of a refuge from some of the difficulties that the world presents. And yes, there might be biological considerations that needs to be addressed, but there are also every one of the humans and their families, these family units that present themselves to us, and we have the privilege really of doing what we as mental health professionals do. And the word, I want to emphasize the word professional actually implies that we are doing greater good. Otherwise, we're just people with special skills that are selling the service out there. The greater good allows us self-regulation and the privilege of that to make ourselves better and make this a better world. So I think it's quite important that we don't forget that's part of the professionalism that psychiatrists and psychologists and other mental health professionals exist for, not just to make money.
Thanks you very much, Daniel.
Yeah, thank you, everybody. We'll see you at the next webinar. And please watch out for this. This webinar is unique because it's open to the public. And so we thank you for the almost 130, 40 people who turned up.
Thank you all.
Thank you, everybody.